The differential diagnosis of abdominal fluid accumulation. Discuss the pathophysiology, the causes of the pathological fluid accumulation, and the old classifications: transudate, which is clear and has low protein; exudate, which is cloudy and has high protein; and modified transudate, which is yellow and has high or low protein. Ascites is fluid buildup in the abdomen. Discuss the differential diagnoses. Portal hypertension can be a transudate, it can be posthepatic or post-sinusoidal, hepatic or sinusoidal. Then also discuss transudates, hemorrhagic fluid, chiloperitoneum, exudate, which can be from peritonitis or pancreatitis, and uroperitoneum. So the pathophysiology. It occurs when there's continuous filtration from the arterial side of the capillaries. The causes of pathological fluid accumulation are increased hydrostatic pressure in the capillaries, or decreased oncotic pressure in the case of hypoalbuminemia, increased permeability of the capillaries, or increased hydrostatic pressure in the interstitial space, or a problem in lymphatic circulation. Increased pressure leads to a transudate, and increased permeability leads to an exudate. So for the old classifications, transudate is a result of increased hydrostatic pressure, and it can be clear or yellow. It has a low protein and low cell count. Exudate is secondary to increased permeability. It can be cloudy, has high protein and a very high cell count. And a modified transudate can be yellowish or reddish. It has a low or high protein and a low or high cell count. Ascites is fluid buildup in the abdomen, often due to organ failure. The fluid can be diagnosed using a positive agglutination test. And the diagnostic methods are using an undulation test, ultrasound. And the differential diagnosis of abdominal fluid accumulation can be obesity, gastric dilation, dilated urinary bladder, due to bladder paralysis, or a cyst. Portal hypertension can cause fluid accumulation in the peritoneum. When it causes transudate, the total protein is less than 40 grams per litre. In the case of posthepatic portal hypertension, for example in the case of right-sided heart failure, you can expect to see the total protein is more than 25 grams per litre. And in the case of hepatic or prehepatic portal hypertension, in the cases of liver cirrhosis, we can expect to see the total protein is less than 25 grams per litre. Transudate fluid is like tap water-like fluid. The total protein is less than 25 grams per litre. It can be found in prehepatic or portal hypertension. It is found with hypoalbuminemia. It can be seen in the cases of protein-losing enteropathies in the intestines and protein-losing nephropathies. In the case of hemorrhagic fluid, the hematocrit can be less than 10%. There's no thrombocytes, and the blood does not clot. The causes can be a tumour, trauma, or a coagulopathy, or a rupture of an abdominal organ. We can also expect to see pale mucous membranes within this condition. In the case of chiloperitoneum, the ascites cholesterol is less than the cholesterol in the blood. It can be seen in the cases of tumours, lymphatic thrombosis or a rupture, or lymphangectasia or acute pancreatitis. In cats, it's commonly seen in FIP. Exudates are normally from peritonitis or pancreatitis. In the case of uroperitoneum, this can be from urinary leakage or a rupture. The place of urinary leakage is not always visible on ultrasound. The dilated urine may look like a transudate. This is why you should always measure the creatinine from abdominal fluids. The creatinine from ascites or the creatine from blood are more than 2. The potassium from ascites or the potassium from blood are more than 1.4. So to summarize, fluid in the abdomen, when it's heart failure, it's usually a modified transudate. Tumours, modified transudate. Infection, we can see an exudate. Thrombosis, we can see a modified transudate or hemorrhagic fluid. And in hypoproteinemia, we can see a transudate. In liver disease, we can see a transudate or a modified transudate.